Tara Sanft. I'm the director of the Survivorship program here at Yale and Smilow Cancer Hospital. This is our third virtual Cancer Survivors series. And it's one of our most celebrated and popular Smilow shares. We're very, very excited to have all of you here with us tonight. You know, National Cancer Survivors Day is an annual celebration in the first Sunday of June. But since the pandemic, our survivorship program has decided every Wednesday in June to celebrate and to reflect and to honor all of our patients, whether you identify as a survivor or not, by bringing topics of interest to you and your loved ones. And we have a really fun series this year of completely fresh and different topics. And I'd love to thank our panelists tonight who helped come up with these ideas in our planning meetings and are here to deliver the content. Yes, Eliza, if you don't mind showing that. So tonight we're kicking off National Cancer Survivors Month with our first topic, restoring your body to integrity after cancer. And we have several panelists who will introduce themselves in just a moment. I'm going to come off screen and let them take it over so that you can have their time with them tonight. Next week, we will talk about living with cancer chronically, and another group of really passionate panelists to share about issues surrounding that topic. On the 21st, we'll talk about cancer and the family, recognizing that this is not a singular episode. This affects everyone in the patient's life. And on June 28th, a really clever topic that I think is very timely, given what the Surgeon General has been saying about social media lately. We're going to talk about myths and social media, and a lot of the survivorship team will be participating in that episode as well. So thank you. And with that, I would like to hand it off to our MC for the night, Dr. Melanie Lynch, and then she will help get everyone introduced and kick off the series. Thank you.
Thanks, Dr. Sanft, for putting together this great series, and we're all excited to be a part of it. Tonight we're going to have each of the panelists introduce themselves, and then we'll move from talk to talk, and we'll take a couple questions to each speaker, and then we'll save all of our other questions for the end, and we're looking forward to a great dialogue. I'm Melanie Lynch. I am a surgical oncologist, and I am the director of the breast surgery program in Bridgeport, and the medical director of the Norma Freem Breast Center. And I'll pass it next to Eliza, or to Andrea, sorry.
Hi, everybody. I'm Andrea Torre, and I am the hairdresser cosmetologist at Smilow in New Haven. I currently do all of the wig fittings along with my colleague, Kim Joyce, and we have started our new beauty program, the Beyond Beauty program, to help with the visual side effects that cancer treatment brings to the patient. And we'll be talking a little bit about that at the end of my presentation. It's nice to be here. Thank you.
Thank you. And Johanna Daddario.
Hi, everybody. Welcome to tonight's presentation. So nice to see so many people on the call. My name is Johanna Daddario. I'm a PA from Gynecologic Oncology, and it is such an honor to be part of this panel tonight. And I will be talking about sexual health and cancer treatment.
And Dr. Ayyala.
Hi, everyone. Thanks for joining, and thanks for the invitation to be on this panel. This is really a really wonderful series, and I'm excited to join everything. I'm an assistant professor of plastic surgery at Yale. I focus mostly on breast reconstruction with a specific focus on autologous reconstruction as well as lymphatic surgery.
And Jonathan Leventhal.
Hi, everyone. I'm Jonathan Leventhal. I'm a dermatologist at the Smilow Cancer Hospital, and I lead the oncodermatology program. I'm an associate professor of dermatology, and it's such a pleasure to be here. And I also recognize a lot of familiar names and just really honored to be part of this great group. Thanks.
Thank you. I'll start by sharing my screen. How's that look? We're good? Okay. Is it advancing? It is, okay. I'm going to open up this topic with a discussion of what I know best, which is breast cancer, and how some themes that we know for breast cancer survivorship impact our understanding of all cancer survivorship. We know that the incidence of invasive breast cancer in the United States continues to increase by about 0.5% every year. And there will be almost 300,000 cases diagnosed in the year of 2023, with an additional 55,000 cases of ductal carcinoma in situ or stage 0 cancer. 43,000 women will die from breast cancer, but this is a continued decrease in breast cancer mortality since the year 1989. So the decrease in breast cancer mortality is due to improved screening, earlier stage of diagnosis when breast cancer is more curable, and improved treatments for both advanced stage and high-risk tumor types. We are now can celebrate that 90% of women with breast cancer will survive 5 years. We're achieving a cure in more and more patients, which means there are more and more women who are breast cancer survivors. The relative survival rate for localized breast cancer is very high, meaning we have a large number of breast cancer survivors, an estimated 3.1 million women in the United States currently. Changes in appearance and body are associated with breast cancer treatment and affect over 2/3 of women who've been treated for breast cancer. We know that our treatments, including chemotherapy, hormone therapy, surgery, or reconstruction, radiation therapy, are associated with adverse short-term and long-term effects that have an impact on body image and self-esteem. So our model of breast cancer, cancer survivorship, which starts prior to diagnosis in the pre-treatment stage, that extends through our local therapies, which include surgery, reconstruction, and radiation, into systemic therapies, and then into survivorship. We all have the ability at each stage of this continuum to improve patient outcomes and to reduce the effects of these treatments on body image and on self-esteem. I'm going to talk briefly about the local phase of therapy, which is what I know best. And we'll start with a discussion of surgical de-escalation. In breast cancer surgery, we have moved from routine mastectomy to routine breast conservation, with over 65% of women undergoing breast conservation surgeries. And we think that breast conservation is better, that survival actually might be improved with breast conservation, which includes a lumpectomy or partial mastectomy and radiation therapy when compared to mastectomy. Women with early stage breast cancer who are treated with breast conservation routinely report higher satisfaction with body image, self-esteem, and sexual function when compared to women who are treated with mastectomy with or without reconstruction. This improvement in outcomes is unrelated to age, unrelated to chemotherapy or radiation therapy use, but is associated with pre-treatment baseline health, body mass index, and sexual function. Oncoplastic breast surgery is a new approach to breast surgery that embraces the philosophy that breast cancer should be treated surgically by effective cancer surgery while maintaining or improving the cosmetic appearance of the breast. This requires teamwork and evaluation of the patient's anatomy, satisfaction, their lifetime risk of cancer, their family history, the local extent of disease, the tumor biology, and engaging a multidisciplinary team to meet the patient's goals. Our idea of oncoplastic surgery is really related to the extent of disease and how much breast needs to be resected and how much breast is there. And we have a number of approaches to addressing cancer of any size in any quadrant of the breast. Our outcomes using oncoplastic partial mastectomy or oncoplastic lumpectomy have shown to be safe, that our cancer outcomes are excellent, and that our cosmetic outcomes are also equally good. One of the newer techniques for approaching mastectomy includes a nipple-sparing mastectomy. I always think this is a very useful picture for understanding what an oncoplastic approach is, where we are able to preserve the entire skin pocket, including the nipple and the areolar complex, and then have our plastic surgery partner perform a reconstruction through this very small hidden incision. This operation is for select patients, but has high patient acceptance and very good outcomes. The largest review of the Cochrane review that looked at multiple studies of participants in nipple-sparing mastectomy trials saw improvement towards aesthetic outcomes and quality of life, while there was no difference in oncologic outcomes. The next area we think about with surgical de-escalation is axillary surgery, and where lymph nodes are removed from underneath the arm for staging purposes. Sentinel lymph node biopsy is a technique for sampling the first draining lymph nodes from underneath the arm and is associated with improved outcomes and decreased rates of lymphedema or arm swelling after surgery. With a sentinel node biopsy, the rate of lymphedema is 5%, the rate of lymphedema or arm swelling after a complete axillary dissection can be as high as 35%. We know the risk for lymphedema is increased with older age, obesity, smoking, and diabetes. Lymphedema or arm swelling is one of the concerning side effects of this operation and can be best controlled when it's diagnosed in its earliest stages. A sentinel node procedure uses a radio tracer or blue dye to map the first draining lymph nodes, and only those nodes are removed for the accurate staging of breast cancer. We've been able to continue to de-escalate axillary surgery and continue to reduce our rates of overall lymphedema by making more and more women eligible for a sentinel lymph node procedure. This includes using chemotherapy as our first course of treatment to downstage or reduce the amount of axillary disease so we can use more minimal surgery. And we've also identified patients where we can omit the sentinel lymph node biopsy altogether. This is for women who are older than age 70, who are clinically node negative, meaning we can't feel the lymph nodes underneath their arm and we can't see them with an ultrasound, who have good biology, hormone receptor positive breast cancer. Another technique that many of us use is reverse axillary mapping, which helps reduce the rate of lymphedema associated with axillary surgery by identifying lymph nodes, the lymphatics that drain the arm. We use a blue dye to map those lymphatics during the surgery so we can avoid injuring them when we're removing lymph nodes. Another way that we're reducing or scaling back our local treatments is with radiation therapy. This is a slide that was given to me by my colleague, Dr. Kevin Dew, that points out some of the recent changes in radiation therapy, including a decrease in time of radiation therapy for women with breast cancer, where we've been able to scale back to 4 weeks as the new standard. And for some patients, even to reduce this back to 1 week or even 5 specific treatments. And newer studies have also identified patients where we can omit radiation therapy altogether. The newest trial that was recently published, and my patients come in and ask me about it all the time, is the PRIME trial, which is for women who are older than age 65, who have an estrogen receptor positive tumor that's smaller than 3 centimeters. For these women, emitting radiation therapy was associated with a significantly higher rate of local recurrence. It was increased from about 1% to closer to 10%, but overall survival was the same, and distance recurrence was the same in patients in those two groups. And then the last thing we can think about is effectively screening for these late effects of treatment from our local therapies, including lymphedema. This should be a prospective model, and that's what we practice at Smilow, where patients are assessed at baseline prior to treatment, and then we continue to screen them over the course of their follow-up care so we can identify lymphedema at its earliest stage when it's the most treatable. So in restoring the body to integrity, the lessons that we've learned from breast cancer is that shared decision-making in a multidisciplinary team is paramount to help us begin to de-escalate from treatments that might have adverse effects, to build a program where we can effectively screen patients for adverse and late effects of treatment, and to continue to address what is important to women. As I say to my residents in the operating room, I call it my Dumbledore lesson, we need to begin with the end in mind, to design our treatments to make sure that we have the outcomes that we would like for our patients. So I'd like to turn this over now to Andrea. Are there any questions? Do we have access to the chat? Okay, we'll have Andrea, we'll have you take it from here.
I can start sharing, I think, once.
Oh, I have to stop.
You have to stop.
Thank you.
Thank you, Dr. Lynch. Let's see, I'm going to start. Here we go. Hi, everybody. So I'm starting with a topic that's pretty well known to patients after they hear the first diagnosis of that they have cancer. But before that, I wanted to start with just the basics, because that's a little bit of everything that what's in this subject tonight, what we're talking about, right? With the restoring the body back to integrity. So I have a couple of different definitions with hair, and what hair is like is fine thread-like strands that grow from the skin. Cancer, which is a disease caused by the uncontrolled division of abnormal cells. Alopecia, which is also known as hair loss, disruption in the body's cycle of hair production. And integrity, the state of being whole and undivided. So what we try to do during all of this hair loss business is to get that back to being whole. First words and thoughts. I believe most patients here after they have a cancer diagnosis is cure, right? So we have a cure for you. You may have a surgery. You have a team for surgery, and they're going to talk treatment, which is chemotherapy, radiation, and so forth. The first thoughts you might have is, am I going to live? And I'm not a betting woman, but I'm going to bet that 99.9% of patients say to themselves, am I going to lose my hair? I get that from every patient that I see for a wig. So what is the attachment to our hair besides that it grows out of our body? Scalp hair has no significant function to humans after all of that. It is pretty much just to give us padding on our head, protect us from the sun, some sensory. So if a little bug flies into your hair, you can feel it. You get your hair standing on end if you get scared, that sort of thing. But it's also, scalp hair is also very unique to the body, as it could be altered, such as cut and styled, where you come and see me. And that is done without any surgical procedures. So that's a plus. Hair is a very big source of identity and body image. I think it's one of the main distressors when people hear they're going to lose their hair. So I always say a bad hair day is very real. Hair loss exacerbates the bad hair day experience. Many women that come in, we talk about hair loss. There's so many women out there, men and women, who have already thin hair. So it's already a problem. And of course, going through treatment, hair loss is definitely exacerbated if the hair is already thin to begin with. And with that, we find that hair loss leads to psychological unrest and distress. There's a lot to be said for when you have a great head of hair, or you're walking around with a beautiful hairstyle, and then you're told you're going to lose your hair. It's what people look at you for and how you look. And it's socially acceptable for some genders to be bald, but not for every gender. So for women, it's a little bit tougher than some men. But I'm not saying that every man doesn't have some issues too, because we certainly have our share of questions about that when men lose their hair. So how do we cope with the hair loss? In the treatment phase, when people are diagnosed, they come to us at the salon in the boutique, and we talk about therapeutic haircuts or clipper cut, maybe go a little shorter. A lot of the patients may be inpatient that we go up to visit. That is very helpful for them because they're bedridden. They are not able to come down to see us, and their hair is shedding as they are in the bed. So we try to do our best to keep that less angst and anxiety along with their treatments. They don't need anything extra to give them any more anxiety with that. We also do our wig fittings. This is something you can help with coping with hair loss. Try a new hair color and try a new style. Wigs are definitely an alternative if you'd like to go that route. And then of course we have head coverings, alternative headwear. The one great thing about head coverings is that you get to keep all that after when your hair grows back, and it does grow back when your treatment is through. So that is one good thing to look forward to. I've never met anybody in 34 years that their hair has not grown back after doing their wigs and their head shapes. So caring for your scalp during this time, a lot of women and men both ask, what do I do? They've never dealt with a bald scalp before. If your hair is still shedding, we always recommend just being gentle as possible. You don't want the hair to mat. Matting is when hair strands get entangled with one another. They start to cause a knot, and that is it's pretty messy. They usually have to be cut out. So back to the therapeutic hair cutting, it helps to go a little shorter each time and also alleviate some of that matting that will happen. Please cleanse your scalp and whatever hair you do have. It's always best to have clean scalp, clean hair. A lot of times the scalp is covered with some little pimples after hair is lost, little pustules, but they usually go away. Nothing to be worried about. Cover up your scalp. Use a hat, a head cover, a scarf, turbans, and always use the sun protection factor. You do not want to be burned on your head. I'm sure that it's pretty painful. You could do that also when you have hair, because it is very important. Any of the ladies out there that don't want their hair color to fade, you can use a little SPF spray on your hair. It's a little trick. Some of the don'ts during this hair loss phase: do not color your hair, do not want to highlight it. You don't want to further disrupt the integrity of the hair as it's already fine. And this is also when the hair grows back. You just want to wait a little bit for coloring your hair. You don't want to use any excessive heat. It will break off the hair you'll have an issue with that for sure. The scalp also, again, just be gentle. You don't really need to dry anything, so just use your towel, soft towel. Tight braids, ponytails, things of that nature. If you still are working with hair, that also is not great for the scalp. I'm going to do a very shameless plug for our Singari Family Boutique program, because all of these subjects are covered along with nail care. And we talk about self-esteem and building back confidence when you have no hair, how to go through the physical changes that come with treatment. It's a 2-hour program. It's free makeup. You get free swag. And you are you're welcome to call us at the phone number here so we can set you up with the next available class. We're hoping to get this to be a sustainable program at the hospitals. So it is gender neutral. We have products for both men, women. We have bags for both. As it says here, we can accommodate patients from 18 to 108. And we hope that it stays as a sustained program. And if any of you would like to come and join, please do. We think it's a lot of fun and a little bit of time away from the medical aspect of your treatment. And with that, I will hand it on over to, I believe, Johanna.
Thank you, Andrea. We do have one question. I don't know if you want to address it now.
Sure.
There's a question from someone about losing. The bigger concern was the loss of eyebrows and the fact that they have never fully grown back. Is there any way to promote regrowth of eyebrows?
So hair on the eyebrow, in the eyebrow area and on the face is pretty much the same as it grows on your head. Hormonal shifts do happen, so you may not get that full eyebrow back. We also have eyebrow kits at the boutique, but we talk about that during our class as well. And you get one in your bag that you get to take home. So eyebrow hair and hair in your head, again, after treatment, it does grow back, but I also believe that certain hormonal shifts do happen. So you may not get that full thick eyebrow back.
I'm also going to discuss a little later about promoting eyebrow hair and scalp hair with some topical and oral medicines that we use.
Terrific.
Great.
Is that it for the questions or anything else that I can answer? Thank you.
And I read this lovely comment from one of our attendees. I can't thank you enough for your help. It's been 6 years since I started targeted therapy. You gave me the best advice. You knew exactly what I needed. My hair looks great, so much more manageable. So grateful.
Wow, thank you.
Thanks for writing that in.
So thank you for the segue. Can you see my screen and hear me okay?
Yep.
All right. So I just have a few slides to share with the folks, the audience that are here tonight about sexual health. And I won't take too much time, and I can't try to fix sexual health today, but I can share with you some validation, hopefully, about how your cancer diagnosis and treatment can affect sexual health and intimacy, and really how it's part of the survivorship wellness experience, in addition to many of the other things that have been discussed as well. So sexual wellness certainly is an important part of survivorship. And I'd like to start with talking a little bit about the number of cancer survivors that are out there. And even in Connecticut, if you look at the American Cancer Society facts and figures, there are, tens of millions of cancer survivors in the United States. There are thousands, I think hundreds of thousands in Connecticut, and all different cancer types. And survivorship is really can be very long-term for a lot of people. So there are more and more and more survivors as we go, which is a great thing because of so many advancements in our cancer treatment options. But I kind of highlighted both in men and women some of the top survivors, and the ones to me that really stand out as far as intimate relationships, sexual health, and impacting sexuality. So in men, cancer of the prostate is the most common survived cancer, followed closely by colorectal cancer, bladder cancer, testicular cancer, a little bit lower on the list there, but still many survivors of testicular cancer, and that can have some fertility impacts as well as sexual health impacts. And then for women, the most common is breast cancer, followed by uterine cancer, or endometrial is the same type of cancer. And then going on down the list, colorectal cancer, cervical cancer, and ovarian cancer. And so really many of the top 10 cancers that have survivors, long-term survivorship, can directly impact sexual health and relationships. So just to validate that you're not alone. So if we think about the definition of sexual health, it's a state of physical, mental, and social well-being in relation to sexuality. And sexuality and sexual health and wellness looks very different for anybody. And there's so many factors. You can think about your sexual identity, age, where you are in the phase of your life, whether you're a young cancer survivor, if you're a woman premenopausal or postmenopausal, whether you're in a relationship or multiple relationships, or you're not in a relationship at the time of diagnosis and treatment. So we think about sexual health in the context of each individual patient. It's an ability to be intimate, and that again takes many different forms. Communicating about sexual needs and desires, and maintaining sexual function. And I actually can't see my own slide here because of the Zoom, but maintaining sexual function and obtaining sexual fulfillment. So really we try to meet patients where you are at as far as my program, which is the Sexuality, Intimacy, and Menopause program. We try to meet you and help you with what you need help with. So there are multiple factors in cancer survivors that can impact sexual health and wellness. And I'm going to go over each of these three categories over the next 3 slides. There are significant emotional challenges that come with cancer survivorship, physical changes, and hormonal changes for both men and women undergoing cancer treatment. The emotional challenges are very real, and I can't underestimate, I can't underemphasize how important emotional challenges are for people who are in a relationship or not in a relationship in regard to their cancer journey. There are changing roles for people. Oftentimes our sexual partner may now become our caregiver and may worry about hurting the patient or hurting you, or just have a lot of anxiety about intimacy. Some relationship stress just from being a cancer patient. Certainly, as we talked about, body image changes, self-esteem changes, anxiety about sexual activity, and just feeling very vulnerable. Sometimes even some embarrassment, depending on the different treatments and bodily functions and how those may have changed. Multiple physical changes depending on the kind of treatment that people have had. So we think about, as great as we're making strides in decreasing the type of treatment, minimizing the side effects, and giving a lot of medication to help with side effects, trying to preserve different things like hair loss, using scalp cooling techniques and other things like that. We're trying to mitigate these side effects, but there still are certain physical changes that come along with cancer treatment. So we think about things like chemotherapy and radiation therapy, as well as surgery. And those can cause fatigue, scars on the skin, pain. We think about sometimes bone pain, but also surgical pain. Loss of sensation for people who've had different types of surgery. So we think about different types of breast surgery and reconstruction, things like flap reconstruction, that people can have loss of sensation. Medical devices are really important. So we have patients who've come and said, well, I don't really mind having intimacy with my ostomy because my partner doesn't mind either, and we just make it work and it's okay. We have some people who really struggle with that. And we have people who struggle even with having a port. If there's a chemo port in your chest, you say, I'm worried if I put pressure on the port that it may cause some problems. And then with things like implants. So there are, for women, there are breast implants. For men, we think of some penile implants, which is more for maintaining sexual function. But there are medical devices that may cause some challenges. Lymphedema, as Dr. Lynch mentioned, there are people who can have lymphedema either of the upper extremities, the arms, or the legs if they've had a gynecologic surgery. And that can really impact intimacy and the positions of intimacy. Weight changes can happen, whether that be hormonal imbalance, weight gain, or weight loss if there are a lot of side effects from chemotherapy or radiation, if people are struggling to keep nutrition and have difficulty staying hydrated and maintaining their weight. So it could either be underweight or overweight, depending on the type of treatment and the side effects. And decreased flexibility, range of motion, and pain again as well. So just having some flexibility issues, maybe not being able to, use the same positions that you may have utilized before your cancer treatment when it comes to sexual activity. So we have to try to work around some of these things. And then hormonal changes. And I can't also underemphasize the hormonal changes that both men and women may experience depending on the type of cancer that they have. So hormonal changes are things like hot flashes and night sweats, sleep disruption. And obviously, we always say nobody wants to have sex if they're tired. A decreased sex drive, so just not having that natural desire to have intimacy with your partner, difficulty with either erections, becoming aroused, or achieving orgasm. And for women, some vaginal dryness and pain. So a lot of hormonal changes, and I didn't even include in the hormonal changes the mood challenges that can come with that as well. There can be some a little bit of mood irritability, even some chemo brain kind of symptoms. So just feeling a little scattered, and that can really impact relationships as well. So what we try to focus on is, number one, validating symptoms and validating sexual concerns. So I want just to remind everybody here that even if your providers don't bring it up, it's okay to bring up the topic of sexuality and intimacy. And it's okay to say, is there somebody I can talk to about this? I'm really struggling. And whatever your symptom may be, we can certainly try to help you, or your provider can try to reach out and find some good resources for you. But really, it's about knowing what to expect. So you can always ask the question of, what's going to happen when I go through radiation? What are the side effects going to be? Or tell me more about this surgery. What can I expect afterwards? And ask about things like menopause, or ask about hot flashes. So don't hesitate to bring up, even if you're not in a relationship, it's totally okay to ask about sexual health and wellness. Open communication with your providers, but also with your family, your partners, the people who are important to you, and the people who you share intimate relationships with. Try to communicate openly. We welcome partners to the appointment so that they also understand what you're going through. I will say probably one of the most common things I hear is, I don't have any desire and I feel guilty about that. And the partner sometimes also feels guilty because of what the patient is going through. They see their partner, their loved one, going through a lot of challenges and struggles, and they feel bad too. So oftentimes there's guilt on both parts. And I say, it's okay, you can meet in the middle and support each other. Experimentation and exploring. And this is one of my all-time favorite images from the American Cancer Society's website about sexual health and cancer. And some people feel a little uncomfortable when I show this image, but I want to reassure you that this is from the American Cancer Society. This is a medical concern. This is very valid. And it's okay to feel a little bit uncomfortable when talking about sexuality and sexual health. But it's also okay to explore and maybe try some new positions if pain is an issue, or flexibility, a range of motion is a challenge. Try some different positions, and we can always help you come up with some ideas, or we can connect you to a sex therapist if that's helpful as well. We talk a lot about exploring other forms of intimacy. So things like cuddling, holding hands, going for walks together, spending time together in different ways, if traditional sex, or the sex that you were used to, may not be possible anymore. And I hope that people who are in the hospital or really struggling with their cancer treatment also feel that they can ask their team for a little bit of privacy, to have some kind of intimacy, even if you're in the hospital, or even if you're really sick. Whatever intimacy means for you is very important, and we want to understand that for you. We can certainly connect you with a physical therapist if you need to. We can connect you with psychotherapists if you need to, for the emotional or relationship challenges. And your team can also connect you with a sexual health specialist, whether it's our team in gynecologic oncology, or for men, there are some great urologists in the Yale system who can help. And we have some great sexual health specialists in the community as well. So that was short but sweet, and hopefully that gave you a little bit of some pointers, and feel free to ask any questions.
Johanna, there was one question or comment about the impact of head and neck cancer on intimacy and kissing. Do you have any experience with that or advice about that?
I should, you're right, and I was remiss. I can absolutely add that. Radiation to the head and neck is absolutely can be impacted, surgery, body image as well. So I will certainly correct that for next time. So thank you for that.
Thank you. Dr. Ayyala.
Can everyone see this? Okay, so like I said, we're going to talk a little bit about oncoplastics and scarring. And Dr. Lynch did actually a really phenomenal job introducing this topic already. We all know that breast cancer care requires a very comprehensive team: medical oncology, radiation oncology, and of course, surgical oncology. And so, like we were talking about, the oncoplastics approach now includes plastic surgeons in this great comprehensive team to work together with the breast surgeons to eradicate cancer while also being very mindful of preserving or restoring your body's natural aesthetic form. So the idea is to work together as a team to provide a very large variety of options. And this can happen at any type of surgery. In lumpectomy, we can reconstruct with tissue rearrangement in conjunction with a lift or reduction on that breast, potentially even do a symmetrizing procedure on the contralateral breast at the same time if necessary. A breast mound can be made following mastectomy with either implants or using your own tissue, or you can choose not to have a breast mound and to be closed as an aesthetic flat contour. And I think it's understated that symmetrizing procedures, while they're sometimes not done at the same time as mastectomy, can be done in a delayed fashion. And you may be a little overwhelmed during the cancer journey, but after cancer is gone, hopefully, sometimes we say in our plastics world that we want cancer to be fleeting, but reconstruction to be forever, that people want both their breasts to match. And it can be difficult to try and wear a bra when both of your breasts are not the same size and to be fitted. So the statistics on oncoplastics, it's been almost 25 years since the government has now mandated that healthcare payer coverage has to be covered reconstruction. This includes any contralateral procedure to achieve the symmetry and any treatment for a sequela of mastectomy. But there's still not a lot of women who are seeking breast reconstruction. And on surveying patients, we found a lot of common reasons is because they don't want to have additional surgery. There's some belief that reconstruction is not available, or it's not important, or it's cosmetic. There is some fear of implants, especially in recent years. And of course, there's fear of increased scarring. People want to be just done and have the least amount of surgery to get their cancer gone. And they don't potentially want another scar on their breast or another scar on their other breast. So why oncoplastics? There's a very, very high satisfaction with the decision to have reconstruction. It's almost 90%. And I'm sure that if we look at the data from this year, while we're so grateful that breast cancer rates are decreasing, the reconstruction rates are increasing, which is great. And patients are very, very satisfied with them. And of course, we do feel that patients have very improved quality of life. We are trying to achieve a balanced chest, want your clothes to fit same way or better, regain that shape or even improve upon it if you wanted something different. Improves your body image, and we do find that it improves psychosocial outcomes. And while in the past we have kind of given reconstruction an afterthought and said, okay, let's do the mastectomy or the lumpectomy and then discuss this later, we find that outcomes are better if we can do this at the same time. So whether at the same time as breast conservation therapy or of course during mastectomy. And like I mentioned before, contralateral procedures can also happen in that same time period to restore symmetry so that you don't have to feel asymmetric for years. And if you haven't already, then there's no time limit. Like I said, the insurance law is now that these are covered, and a lot of patients come to me and say, hey, how many times can I try to get this right? Or if my breast change in the next 15, 20 years, can I come back and have a different outcome? And the answer is yes. And like Dr. Lynch mentioned, reconstruction is safe and it does not affect the risk of local disease reoccurrence. So of course, this is a lot of surgery, and we know that surgery creates scars. I wish we could do scarless surgery. And sometimes people come to me as a plastic surgeon and they're like, oh, you can make a scar go away. And I wish I could, but we can make it better. Scars aren't great, especially in the breast cancer world. A lot, up to 20% or 18% of women are experiencing scars that they didn't really expect. And up to 30% are not very happy with how their scars have turned out, whether in the immediate postoperative period or long-term. So scarring is a significant concern. It's a large source of dissatisfaction with overall the surgical outcome, even if the contour is nice. Scarring can be painful. It can be usually numb around the scar area. Sometimes people have a residual hypersensitivity, itching or tingling sensation. And in scarring, especially around the axilla or, mobility, it could be tethering and restricting of your motion. And I think that we've done a lot of deep dives into how people feel about their scars. And we found that the most important predictor of the satisfaction of the scar is shared decision making about expectations. So it's really important to know, yes, we're going to remove your cancer, and yes, we're going to do a reconstruction, but how is the scar going to look and where is it going to be on my chest? So the idea is a couple of questions, how can we optimize our surgical approach to minimize a scar appearance or burden? How do we care for the scars in the immediate postoperative period? How can we mitigate the scar burden long-term? And how do these scars impact survivorship? So Dr. Lynch talked about this a little bit too, which is great. But incision planning we do together. In terms of lumpectomies, oftentimes we're trying to design the scar to hide in these existing resting skin tension lines. We have these all over our body, and you can notice that, when you smile or when you move your arms or legs, or if you just pinch your skin, you can see that if you pinch in one direction or a different direction, one of them is much easier than the other, and it's easier to hide scars in relaxed skin tension lines. Same thing with mastectomy, but everyone has different size and shaped breasts, so the incision that we plan is what is right for you. Traditionally, we make a transverse or horizontal incision that most people are familiar with, and this is often done when we can't preserve the nipple and we're taking it away, so we're incorporating that into the scar. But we actually started to do something different, where instead of that horizontal incision, we're now making it a vertical incision. And if anyone knows anyone who's had cosmetic surgery, when we do a breast lift, we often follow a vertical pattern. And the reason why is because if there is some horizontal excess in your breast, we can actually lift and reshape that at the same time in the mastectomy. If you have a larger breast or a more tonic breast, then we can do a larger skin excision. So that is reducing both the horizontal and the vertical excesses. This is called an inverted T or a WISE pattern. If anyone has heard of this, we do this for breast reduction as well to kind of hide those scars. And of course, like Dr. Lynch touched on, the inframammary incision is really the best aesthetic incision. Nipple sparing mastectomy, it can hide underneath the contour of your breast. So you can kind of just forget about it because you never see them. And of course, when your axilla is accessed for either a sentinel node or an axillary lymph node dissection, you will have a scar either hopefully through the mastectomy incision, but sometimes also in the hair bearing area if the incision is not amenable to it. So what do we do in the immediate post-op scar care? I usually tell people after the 1 or 2 weeks when the wound has healed a little bit, I usually start silicone sheets. I think in the past, a lot of people have been using vitamin E, but now the new evidence is showing that silicone sheets are the best way to treat scars. And I usually tell patients to use it 24/7 up to 6 months. You don't have to change it every day, but if it gets wet or dirty, you can change it. And we think that the pressure is improving occlusion. It really hydrates the wound bed, decreases tension on the wound. It optimizes capillary blood flow, so it stimulates healing. And silicone is negatively charged, so there is some basic science that looks at the alignment of collagen cells, and the scar actually forms in a straight line more than a disorganized fashion, which can cause hypertrophic scarring. But of course, a little unusual to say is keep your breasts out of the sun, but you never know. So the sun is really, really bad for scars. Up to a year afterward, the tanning of scars is very different than normal skin. So you have to be worried about hyperpigmentation if your scars are in the sun. And long term, so if you already have a scar that's been there for a year or two and it's raised or hyperpigmented or even keloiding, meaning that the scar is growing outside of the area where it already is, then there are options. Number one is we can take it out, start again, create a fresh scar and start silicone therapy afterward and try to optimize how that scar is going to heal. Can inject steroids to kind of calm down that hyperpigmentation in a conjunction with a little pressure therapy. You can do a combination of both, especially in heavy keloiding people. We will often excise it and also inject steroid at the same time to prevent it from coming back again. Cording or tethering, a lot of people sometimes in the axilla can find that they have some of hard cord or tethering of the scar. And so we start with non-surgical techniques like massage, physical therapy, deep tissue massage. But really, if this is not working and it's significantly impacting your range of motion, we can consider a surgical scar release. So, I mean, definitely scar characteristics, it does affect physical functioning at some times, but definitely social functioning if the scars are in an undesirable area or is unsightly. The importance of shared decision making between your surgeon and the patient is it's really important to draw out where are the scars going to be and how are they going to look and what are the patterns, and when I'm wearing clothes, how are they going to look? And it's never too late to address uncomfortable or unsightly scars.
Awesome. And do we have any other questions for Dr. Ayyala now? We can also add any questions that you've got to the chat and we can raise them at the end. And Dr. Leventhal.
All right, great. Can everyone see my screen? So I'm John Leventhal. Nice to see you again. So I'm going to discuss today dermatologic conditions that can happen in survivors. And we see a lot of this at Smilow in our cancer patients. So really the skin, hair, and nails are among the most common things that are impacted by cancer therapy. And these toxicities can happen during treatment, but certainly they can also persist and even evolve over time and impact our cancer survivors. So seeing patients, we know how important these toxicities are. They can really impact not just the activities of daily life, but really such a negative impact on our emotional quality of life. There's such a visual reminder of cancer. Many patients might even view it as like a stigma. And so these are really important to evaluate and manage and treat. And as dermatologists, we absolutely can provide medical and aesthetic treatments to improve and restore the body image and health of our survivors. So we already learned a lot about scarring from Dr. Ayyala, so I'm not going to repeat much of that. But I will say, in addition to surgical sites, we can also find scarring in areas of chemo ports, as well as sometimes chemo can leak out into the skin and cause extravasation injury. And especially patients who have darker skin types, they're more prone to get keloids and scarring. Here's an example of a hypertrophic scar around a port site. And we can use a variety of topical medicines and injecting steroids into our thickened scars of patients to improve them. In addition to scarring, we also can have a lot of skin texture changes from radiation therapy. And here's some examples of fibrosis, in which the breast can contract after radiation therapy. This can really impact quality of life. It can also lead to functional impairment. Pigment changes are possible as well from radiation. And here are dilated blood vessels in the skin. So we can offer various treatments to improve, especially the pigmentation and the vascular blood vessel changes with laser therapy. The fibrosis is challenging to treat, but we can offer laser therapy and certain oral medications in addition to physical therapy to improve that. And finally, patients who receive a stem cell transplant can get chronic graft versus host disease of the skin, which can also present with rashes that change the skin texture and the skin can become thickened. And we're able to treat these patients with a variety of topical and oral medicines. We learned a lot about hair changes earlier. So fortunately, the vast majority of hair loss that happens in cancer patients, the hair does regrow. However, I will say in my clinic, up to 1/3 of cancer patients will present with sometimes sparser hair, the hair texture or even the color changes. So there are persistent hair changes which can occur after chemo. I also see many patients with breast cancer who are on endocrine or hormonal therapy, and they present with a female pattern type of hair loss with thinning in the front and mid part of the hair. And radiation can also result in hair loss or alopecia. Here are some examples of alopecia that we see after chemo and after radiation. Sometimes even after targeted therapy, the rashes can be so severe that they can be associated with hair loss, and the hair regrowth occurs when we treat those patients. And so we can offer a variety of topical and oral treatments to promote hair growth. There's really only one thing that's approved by the FDA to help prevent hair loss during chemotherapy in women with breast cancer, and that's scalp cooling. But I really wanted to focus on our cancer survivors today. And so Rogaine over the counter can promote the speed of hair growth after alopecia from chemotherapy or endocrine therapy. And we started to use low dose oral minoxidil, which is the oral form, which can also promote hair growth and can really be quite effective. Earlier, I think in the chat, there was questions about loss of hair on the eyebrows or the eyelashes. And this is something that can also occur in maybe 20–25% of patients after chemotherapy. And Latisse or Bromatopros gel can actually help promote hair regrowth in those areas. Fortunately, most of the time, the eyebrows and eyelashes do regrow fully, but occasionally patients will tell me that it's really quite sparse. And so they might consider also eyebrow stencils and even permanent tattooing to help restore the aesthetics of it. And so I think it's important for patients to be aware of that. And then finally, with regarding hair, sometimes too much hair happens with certain types of cancer treatment, and you can get excess hair or hirsutism. This is especially common with certain types of targeted therapies, such as epidermal growth factor receptor inhibitors. And so we can use topical medicines like Vanica or eflornithine, as well as oral medicines to help reduce the hair, and shaving, waxing, and laser hair removal, as well as skin lightening creams can help improve the aesthetics of that as well. Nail changes are very common from a variety of cancer treatments. The nails can become brittle. The nail plates can lift off of the nail bed. You can get nail infections and blood under the nails that can even result in loss of the nail, as seen here. And dermatologists are able to help promote normal nail growth by using growth stimulators like biotin, various nail lacquers to help promote the moisturization of the nail. Sometimes the nails grow back thicken, almost looks like what patients say I have fungal infections, and there's certain creams that can help thin the nails. And finally, if the nails don't grow normally, sometimes they might pierce inward and be grow out with ridges, or have just persistent infection from the nail just piercing into the skin. You can actually see a podiatrist or a hand surgeon to help remove the nail plate, and then that will cure that problem. There's a variety of different rashes that we see during cancer treatments. Fortunately, most of the time the rashes go away. There are certain rashes that might persist, especially after treatments with immune stimulating treatments like immunotherapy or immune checkpoint inhibitors. One example here is vitiligo, in which the patient loses their skin pigment. Other changes can happen as well, such as blistering diseases or psoriasis. So as dermatologists, we're able to treat these conditions with a variety of topical medicines, as well as light treatment, oral medications as well. For patients with vitiligo, we're able to use phototherapy to help restore normal pigment of the skin, which can be quite effective. And many patients, particularly those who have darker skin types, can develop hyperpigmentation after their cancer treatments when they develop rashes. And so we're able to treat these rashes with skin lightening creams, and sometimes laser therapy can be effective as well. I think sun protection is really important, regardless of the type of rash you have. The sun can certainly exacerbate, worsen the pigmentation, as Dr. Ayyala mentioned earlier, for scarring. So sun protection and gentle skincare is really important. And then finally, you heard a little bit about lymphedema earlier. And so there are treatments for lymphedema that can occur after surgery and radiation. massage therapy, physical therapy can be very helpful. We have great physical therapists here at Smilow. Compression therapy is really helpful, whether it be a sleeve or compression stockings. And finally, there are some emerging surgical treatments to replace the lymph nodes, which might be helpful in certain candidates. What's interesting after certain types of cancer treatment is that there can be an increased risk of skin cancer, actually. And this can occur from the underlying immune changes of the cancer. It can occur from immunosuppression or radiation. And so it's really important to ask your doctor, am I at increased risk of developing skin cancers? To always protect yourself from the sun, use sunscreen. And for those that might be at risk, to see a dermatologist to look for skin cancers, because early detection is key. Most skin cancers, when detected, can be easily treated with very, very positive outcomes. And here's some examples of melanoma, basal cell, and squamous cells that have occurred in my cancer patients after treatment. And the last slide is a slide about wrinkles and loss of volume. Many of my cancer survivors in clinic will tell me that they just feel that their skin is aged after going through all these types of cancer treatments and chemo and radiation. And there's been a really growing field of restorative oncodermatology and assessing how can we improve the aesthetic outcomes of cancer patients. And this is a study by my friend, Dr. Rossi at Sloan Kettering, where cancer patients who had increased wrinkles would receive Botox. Here you can see improvement of the wrinkles. And those who reported loss of volume on their face would have filler. And those who reported kind of lackluster skin and dryness could have laser therapy for rejuvenation. And I think this is a really important growing field to fully address all the health concerns of that involve the skin. So with that, I'll stop and thank you, and I'll gladly take any questions.
That was also an awesome presentation. I learned so much too. That's a wonderful clinic to have. There were a couple specific questions. One question on how to address scars on the abdomen from ovarian cancer surgery and subsequent hernia surgery. And if you have any advice on management of abdominal scars.
Sure, I can take this one. So it really depends on what we'd have to take a look at what your scar looks like and how it feels. Sometimes scars on the abdomen, especially in the lower area, can be tethered down. And so upon moving, it can be uncomfortable because the scar that you see on the skin is not the only scar that is there. When you're going inside the abdominal cavity, there's also scars underneath in the fat, the fascia, when we pull everything together. So sometimes if it's really tight on the inside, it actually might not be as tight on the outside. And you may benefit from a scar release or revision of not just the skin, but also underneath. In terms of non-surgical techniques, because I'm sure no one wants to have surgery, aggressive, really deep tissue massage. I have found that sometimes after surgery, patients are not, they maybe don't feel comfortable stretching out completely. And so after not stretching out and really hyperextending your back, your body kind of heals in this contracted position, and it can be difficult to stretch that scar tissue out. And that can be done non-surgically. We've had a really good success with physical therapy and deep tissue massage. If that doesn't work, then we can definitely explore surgical options.
From a skin standpoint, sometimes laser therapy can like such as fractionated laser can actually help with scarring, depending on how severe it is. And if they're just smaller areas of thickened scarring, just persistent injections of steroids every couple months can really help improve the appearance, but also the symptoms. A lot of scarring that's thickened can be itchy or irritated. And so steroid therapy can really help the symptoms of that.
Dr. Leventhal, there was a similar question about skin grafts and skin graft donor sites from the back of the thigh. Do you think laser therapy would be a useful technique for pain associated with those sites?
I think a lot of it depends on the type of scarring. Is the problem the pigmentation? Is the problem the texture? Is it hypertrophic or thickened? And so I think depending on the particular case, yes, injection of steroids, laser therapy can certainly be helpful.
There's an interesting question about eyebrow tattoos and if that has any role in ability to have MRI testing. Are those tattoos done with any kind of a magnetic particle?
A really good question. And as it turns out, some tattoos do have metallic particles, and that those can actually be a problem for certain types of imaging like MRI. And I think that it's important, if you are going to get an MRI, it's one of the questions that are usually asked. You have a tattoo, to ask your tattoo artist, are there any metallic particles? Many times it's fine. If there is a concern, then instead of an MRI, your oncologist might order a CAT scan. That's a really great question.
I'm glad I came tonight. I've learned so much. Are there any other over-the-counter scar creams or treatments that you think are particularly effective that patients should know about?
There are a lot of brand name scar creams that are relatively expensive. And I do think that the generic, I mean, honestly, I pull up Amazon in the office with my patients and I'm like, listen, just Google or Amazon any silicone scar, tape, sheet, or cream. It really depends. I think on the breast and the body when the scars are a little longer. And it's nice to have that silicone sheet, not only for pressure, but it prevents chafing against the, your bra or clothes if you're wearing them. But if it's in a more visible area, let's say the port site and it's in the sun, then there's actually really great scar creams, again, generic, anything that has silicone in it and has SPF. So you want to double whammy, protect against the sun. And the gel is usually a clear gel, so it doesn't look like you have like a big Band-Aid on you all the time if people are seeing that area. But any generic and you don't have to get it, no pharmacy needs to prescribe it for you. I do think that if you want insurance to cover it, I think that you can prescribe silicone sheets and creams. I'm happy to do that, but otherwise it's pretty cheap on Amazon. Not that I'm plugging Amazon or anything.
Okay. What dose do you recommend for biotin? Is this for?
So the dosing is just the recommended dosing on the bottle, not, one daily, definitely not a fan of super high dose. I think for biotin, for promoting hair and nail growth, the data is a little bit iffy. I think that medications like Rogaine over the counter certainly work better at promoting hair growth than just supplements, vitamins like biotin. And then regarding promoting nail health, I think I'm always an advocate of doing anything you can in your power that's safe to help promote normal hair and nail health and regrowth. So I think biotin's fine to take. Some cancer center dermatologists also recommend certain types of collagen supplements like Biosil, which sounds like biotin, but it's actually collagen, and that's just over the counter. And the recommendation is just the daily recommended dose, not like 10 pills of it.
Okay. In any of your experience, how likely is it that health insurance is going to cover treatments for chemo-associated cosmetic issues?
Really good question also. So we have a great team here at Yale of aesthetic dermatologists who are able to get certain types of aesthetic treatments covered by insurance, whether it be pigmentary changes, texture changes. Many of these are associated with symptoms. They're not just purely cosmetic. And so I think it obviously varies on a case-by-case basis, but when you see a dermatologist, they can certainly try to do all they can to get it covered.
There's a question about lymphedema of the legs after ovarian cancer surgery. And I can chime in a little bit on lymphedema because the important thing is to have serial exams to help understand the extent of lymphedema and the progression of lymphedema. It's often helpful to have a baseline measurement before surgery. And then if that measurement's not available, to follow leg circumference or arm circumference after breast cancer surgery over time. physical therapists have very effective therapies for helping to manage lymphedema, to help reduce both the circumference of the limb and the symptoms of heaviness that can come with lymphedema. And compression garments are going to be an important part of that. So it does require follow-up. You know, in the breast cancer world, we recommend follow-up every 3 months for screening for the first 2 years when lymphedema is most likely to happen. Any other comments on lymphedema screening or treatments?
No, definitely. I mean, you hit the nail on the head. Complete decongestive therapy is the absolute way to go, and screening and surveillance is so important in breast cancer and ovarian cancer, especially if you've had, you know, a pelvic dissection or groin dissection, or any sentinel nodes from the groin as well. To ideally, we would have those people get measurements beforehand and have you actually connected with a physical therapist or specifically lymphedema therapist before you have surgery, which we're trying to do with the breast cancer world. But I totally agree with the ovarian cancer world too. We're trying to start that program and then following measurements so that we can get you onto complete decongestive therapy and compression right away if we find something. If you're past that point, you've already noticed pitting or swelling and lymphedema developing, number one, get connected with a therapist, start in therapy. And if that is not helping, then definitely you can come and seek surgical options in terms of lymphovenous bypasses and transplants and things like that. And we can run a bunch of imaging diagnostics to see the status of your lymphatic channels and see what you could be a candidate for.
We're so excited that you're part of Yale, Dr. Ayyala. That's such a useful skill. We're really excited you're here.
I'm just happy to be such a part of a great, great, great team. So I couldn't do what I do without you guys.
And there's some questions about skin cancer screening and guidance on sunscreen and sun protection, especially for patients who are more vulnerable, like after a stem cell transplant.
Great question. So the short answer is any sunscreen that's SPF 30 and above and that you like and will actually use is what I recommend. I don't think one particular brand is better than the others. There's physical blockers, which have zinc oxide or titanium dioxide. They're usually whitish, more pasty, and they block the UV rays. And then there's the chemical blockers, which usually go on a little bit more elegantly. You can't really tell that you're wearing it. There's been some concern over the last few years about if you use the chemical blockers, do they get absorbed in your blood? The short answer is they do, but there have not been any documentation of harm to the body. A lot of things that we eat and put on our skin probably do get absorbed to a small degree. So any sunscreen you'll use is great. Obviously, seeking shade, protecting your eyes with sunglasses, reapplying sunscreen is very important. And a good time to get screening really depends on your overall risk. So if you have a very strong family history of skin cancer, if you are someone who's had a lot of sunburns growing up, very light skin, lots of freckles or moles, then you might want to get screened sooner. Some of the risks, like after radiation, actually happen over 10 years later. So there's no rush to get it right away, but it is something that you should incorporate in your routine health screening several years later. So a lot of it depends on your risk factors. We have a great survivorship clinic here who's just terrific at triaging and assessing the risks and getting patients plugged in with dermatologists.
All right, I think we've seen all the questions, and what an awesome panel, and what a great group of experts to pull together. I learned so much tonight as well. And Tara, I guess I'll turn it back over to you.
You. I thought maybe I would hop off and let you guys do it, but I wanted to hear, and it was riveting. I learned a lot too, and it's always good to have a refresher. I see just through the chat, and I know, Jonathan, you answered this, but I don't think the panelists or the attendees can see it. So there was a question for you about what was recommended for nails that are thick and yellow, and you answered, but I think it only went to maybe us. I'm not sure. And then there's something about self tanners. If there's anything that you recommend about that, could you comment?
So for thickened nails, urea cream or ammonium lactate over the counter can help thin the nails down. Tanning beds are absolutely terrible. You should not do that. Self tanners and those chemicals that you can use are perfectly fine and preferable, and they're totally safe.
And
Occasionally,
Andrea, I wanted Andrea, sorry, go ahead.
you can get irritated from, your skin can get irritated from those self tanners, but in general, very safe.
Andrea, I see my patients all the time who want to know where to get these things. And, they might be, just to bring it full circle, can you give us like a little bit of an overview of what the boutique sells, and maybe even think a bit about what Johanna had talked about in terms of intimacy? I know that it can be really tough to buy some of the stuff sometimes at CVS. So what does the boutique have that's been mentioned here tonight, where people could come to Smilow, the first floor, go to the boutique and buy this in a totally normal, non-judgmental fashion?
We're talking about the boutique in general. Of course, we have mastectomy. We have a mastectomy fitter, so we have all of the bras and prosthetics. We have bathing suits. We have seasonal wear. We have hats, scarves, turbans. We have beautiful outerwear, certain things that you can wear. So if you have a port, we also sell items such as we have products for skincare that are recommended for people going through chemotherapy. So it's light on the skin, nothing that's too much of a barrier, still allows the skin to breathe. We are selling a little bit of the lip glosses and the makeup that we're talking about with our beauty program. So eyebrow kits and certain little items that you would need if you needed to spend the night in the hospital, such as slippers and outer sleepwear. For Johanna's side, I'll let her answer for what because we do sell for the clinic as well for her. So I'll let her describe what we have for patients there.
Yeah, thank you, Andrea. So we do have, there are some intimacy products available at the boutique, and the staff at the boutique is wonderful in helping. If you have questions, you can ask. And I tell everybody, tell them Johanna sent you, and they'll know what you're looking for. But there are some herbal remedies for things like hot flashes that have been available in the boutique, but also I can help you order them as well online. Behind the desk, not necessarily out on display, but we have something called vaginal dilators, which are helpful for women who have some tightening or scarring of the vaginal tissue and need some help kind of stretching the vaginal tissue. So those are available at the boutique, but they're held kind of behind the counter a little more discreetly, so you can feel free to ask for them. And I will put in a plug for a website that we really like to recommend called medamour.com. MEDAMOUR, which is a medically supervised website that has some really nice sexual health and intimacy products, some lubricants, vaginal moisturizers, things like dilators as well, and just some fun things for patients and or partners to explore a little bit. So feel free to check that out.
Fantastic. And believe it or not, Dr. Ayyala had to go to the OR. So as you can see, we're all dedicated to patient care, even at almost 8 o'clock at night. So really inspiring session. What a great way to kick off Survivors Month. I cannot thank you enough. The panelists, you guys are fantastic. You dedicated so much time preparing and coming and presenting. And then of course, all the attendees for sticking with us and your attention and your thoughtful questions. And we'll sign off tonight. Thank you all. Have a great one.
Thank you all. Good night.
See you next week. Same time. Bye-bye.
Bye.